Assalamu alaikum and good evening, everybody. And thank you for attending our webinar, IFSO MENAC first webinar of 2026. And we choose to pick these two topics of portovenous thrombosis after metabolic surgery and bleeding. Opposite subjects, but at the same time, almost interactive with each other. So, and for that, we choose senior panelists and senior presenters to present this very interesting subject.
Thank you, Dr. Ali, and again, welcome you all to our webinar today. I just would like to remind everyone that this webinar is recorded for later viewing, if you like. If you have any questions about the webinar, about any of the sessions, please feel free to type them and we'll be able to respond during the discussion after each session. Now, we are delighted to have in our panelists Dr. Phil Shower, who I have no doubt all of you know for his contribution to the field of metabolic and bariatric surgery through his clinical work, his research contribution, and the training of many surgeons. Professor Shower is currently working as a professor of metabolic surgery at Pennington Biomedical Research Center of Louisiana State University. We're also joined by two other leading experts in the field of metabolic and bariatric surgery, Professor Mohammed Abu Zaid, who is a professor of bariatric surgery at Ain Shams University, and also Dr. Ala Wafa, consultant bariatric surgeon and assistant professor at Misrata University. So welcome, our panelists. We will start the sessions today. Our first talk by Dr. Rodrigue, who is a clinical assistant professor at the Lebanese American University Medical Center. And he will be talking to us about the real risk of portomesenteric vein thrombosis after metabolic surgery. So without further ado, Dr. Rodrigue, the floor is yours.
Dear President, dear colleagues, I am honored to be part of this interesting webinar, which is the first for this year. Thank you, dear Muhammad and dear Ala, for this opportunity and your kind invitation. My talk will cover the real risk of portomesenteric vein thrombosis after bariatric procedures. I have nothing to disclose except that this complication has not been encountered in our practice, so I will approach this topic objectively and will share our institutional experience at the end of the presentation. This is my case mix disclosure slide, and this is the outline of my talk, highlighting specifically on the real risk and how to prevent it. Portomesenteric vein thrombosis is a serious and potentially lethal complication after laparoscopic surgery. It is highlighted by the fact that it's 3 times more frequent in laparoscopic splenectomy when compared to open splenectomy. It is defined by the formation of thrombus in the portal, mesenteric, or splenic vein. Usually, these are the center of confluence of all traumatized vessel in our metabolic bariatric surgery, and specifically in the sleeve gastrectomy. Obstruction can be partial or complete, and that would dictate the symptomatology and the severity of the disease. It has been reported in different laparoscopic surgeries, such as cholecystectomy, right hemicolectomy, fundoplication, and splenectomy. It was first described in 1895 by Elliot in a 25-year-old male patient presenting with a strangulated inguinal hernia. The hernia was reduced without further imaging. The patient deteriorated. On a controlled CT scan, he had dead bowels and mesenteric vein thrombosis. After metabolic bariatric procedure, it was reported in 2004 after Roux gastric bypass and 2009 after sleeve gastrectomy. This complication is rare in the general population, but the incidence increases markedly after bariatric surgery. particularly the sleeve gastrectomy, 0.2 to 0.5% after bariatric procedures, up to 1% after sleeve gastrectomy. Preventive strategy matters. A routine 30-day extended low molecular weight heparin prophylaxis is associated with a decreased of 60% relative reduction of this complication when compared to selective use of anticoagulation. Center experience matters also. We have higher portal mesenteric vein thrombosis rates in low volume centers. This likely will reflect the standardized thromboprophylaxis and the lack of postoperative pathways. Cross-published series, portal mesenteric vein thrombosis after bariatric surgery remains uncommon, 0.2 to 1%. Outcomes, however, vary between studies. We have a higher mortality rate in the series of Shaheen in 2017 that reaches 3.37%, and that's mainly because we have an older cohort study, and the patients usually present in a late condition with an established already intestinal ischemia and advanced thrombosis. Regionally, in the MENA and the Pan-Arab area, the survey that was conducted by Ahmed Bashir in 2019 on 13,000 patients had an incidence of 0.23% and highlighted the higher risk of portal mesenteric vein thrombosis with a history of travel. Around 23% of those patients had a recent travel history. This will highlight the added risk of medical tourism with an early, long travel, dehydration, limited post-operative follow-up, and the absence of extended thromboprophylaxis. So portal mesenteric vein thrombosis results from the cumulative effect of Virchow's triad. One, the venous stasis, pneumoperitoneum and reverse Trendelenburg reduced the portal and the mesenteric venous flow, hypercoagulability, and obesity-related chronic inflammation, which is amplified by the post-operative inflammatory response, endothelial injury, and the surgical manipulation and thermal spread from the energy devices. And whenever we have all these factors together, the risk is cumulative. This large prospective registry from Michigan group shows that portal mesenteric vein thrombosis is uncommon, but not random. Most cases occur after sleeve gastrectomy and typically 2 to 4 weeks post-op. Independent predictors include prior thromboembolic events, liver disease, major post-operative complications, and the sleeve itself. It is interestingly worth mentioning that hyperlipidemia appeared protective, and this is likely reflecting the beneficial effect of statins on the hepatic inflammation and steatosis. So we have several contributing factors, and this complication is multifactorial. The risk is cumulative across the perioperative period involving patient and surgical procedural factors. In the preoperative risk factors, the risk is already present before surgery. So obesity creates a chronic pro-inflammatory and prothrombotic milieu. Thrombophilia, whether inherited or acquired, also carries a trigger, and oftenly it is unrecognizable before the surgery. To note that factor V laden is very common in the MENA area, with the highest prevalence in Lebanon, around 14%. Added to this, we have the smoking, the gender, with the central obesity in female carries a higher risk, and the hormonal factors such as oral contraceptive. Intraoperative factors converge on venous stasis and endothelial injury. One, we have the positioning, the reverse Trendelenburg, which will increase the venous pooling in the lower extremity and reduces the portal venous flow. Pneumoperitoneum, whenever the intra-abdominal pressure is higher than 14 millimeter, also will reduce the venous return and promote stasis. The longer the operative time, specifically in higher BMI patients and challenging cases, will cause prolonged venous stasis also. Energy devices and the vessel sealing devices that will cause thermal damage to the nearby vascular structures, and the stapling technique, which will cause localized inflammatory process. So to summarize the major things that are related to our metabolic bariatric procedures, and specifically the sleeve, the first contributing factor would be the pneumoperitoneum. So we have an inverse relationship between intra-abdominal pressure and the portal venous flow, as shown by Tagashi. So whenever we have an increased intra-abdominal pressure more than 10 millimeter, we have a decrease in the diameter of the venous trunk and the blood flow. The second contributing factor, we have the thermal spread and the thermal effect of the vessel sealing devices on our vessels, over the greater curvature, the left gastroepiploic and the short gastric vessels during a dissection. So we need to be more close to the stomach rather near to the gastroepiploic arcade to avoid thermal spread and injuries. Be careful when dissecting the posterior stomach not to have close manipulation of our devices close to the pancreatic tissue. When compared together, we had no significant difference in thermal damage between the harmonic to the scalpel when compared to the ligature at maximum output power. But if we compare the 5 millimeter ligature to the 10 millimeter ligature jaw, definitely the depth of thermal spread is less in the 5 millimeter ligature. The third contributing factor is the liver compression, as it has been shown in the series by Villagram. So most portomesenteric vein thrombosis cases occur despite standard low molecular weight heparin prophylaxis, suggesting the mechanical component. Liver retractor in this case was the natensen in 4 out of 5 cases. This may compress the portal triad, causing hepatic congestion and portal flow stasis. And this also have an effect that is more likely dependent on the operative time. In this case, it exceeded the 90 minutes, not much, 93 minutes. So in our practice, a fixed natensen liver retractor is never used. We replace it by the 5 millimeter instrument suction irrigation tool to avoid persistent compression over the liver, especially in higher BMI cases. And then we have the post-operative risk factors, the inflammatory response, which will trigger hypercoagulability and systematic inflammatory pathways towards thrombosis, delayed mobility, which is no longer the case, especially worldwide with the ERAS protocol, dehydration, reduced gastric capacity, and hypovolemia, specifically when we are using lower size bougie and in sleeve patients that in the post-operative period we have nausea, and this will reduce the oral intake and may contribute to hemoconcentration. So the dehydration will manifest as hypovolemia and hemoconcentration, as reflected here on this table also from the Villagram study, with the borderline skyrocketing levels of hemoglobin and hematocrit. Exceptionally, we see those levels 15 to 16 gram per deciliter in female patients especially. So this will show how hemoconcentration and dehydration can cause portomesenteric vein thrombosis. And this correlates directly with the inability to drink, especially in this series, where the bougie size was around 34 French. Clinical presentation is often non-specific, deceptive, and misleading. It depends on the degree, the site, and the extension of the disease. To note that 12% of those portomesenteric vein thrombosis are asymptomatic, as shown by the series of Gomez. The red flags is persistent or worsening abdominal pain in dehydrated patient, typically presenting 7 to 28 days after discharge. Other symptoms are often misleading and that can be compared to any post-operative complaints after bariatric surgery. As for the diagnosis, contrast-enhanced CT, portal venous phase is the gold standard for portomesenteric vein thrombosis diagnosis with a very high sensitivity. The CT will confirm the diagnosis, will rule out other alternative causes such as leak, bleeding, and assesses the bowel viability. It also defines the extent of the thrombosis, whether portal, splenic, or mesenteric, which is predictive of severity and prognosis. Doppler ultrasound is a second modality, but it is less sensitive and may help in the follow-up period. The two core goals in the management are simple but critical. We need to stop the thrombus propagation and progression and prevent intestinal infarction. Therapeutic anticoagulation is the cornerstone of management and is effective in the vast majority of cases when started early. Hydration is not supportive care. It is a therapeutic option, and especially in post-bariatric patients that are prone for dehydration. Anti-10A level should be taken to make sure that we are achieving adequate level of anticoagulation. Escalation therapies such as thrombolysis and surgical thrombectomy are reserved for failures or progression of ischemia, but not as a first-line therapy. Surgery is not a treatment for portomesenteric vein thrombosis. It is a salvage strategy for ischemia, perforation, peritonitis, and if a splenectomy is needed. With early recognition and anticoagulation, recanalization rates are high and mortality remains low. The duration of anticoagulation remains heterogeneous, but short courses are inadequate in high-risk patients. Direct oral anticoagulants have limited evidence, and especially in the acute phase. And definitely, we need to have a thrombophilia workup before initiating the anticoagulation or along what the patient presents to us. All these factors can be mutated in a specific group of patients, thus increasing the risk of portomesenteric vein thrombosis and any type of thromboembolic events. What about prevention and prophylaxis? Evidence remains heterogeneous with no consensus on optimal agent or duration. However, extended prophylaxis appears beneficial when the risk is adjusted. Current risk models published by Aminia supports more than 2 weeks in high-risk patients and more than 4 weeks in very high risk patients. Routine extended thromboprophylaxis has been studied by Kuva and showed that 30 days routine low molecular weight heparin reduced the risk from 0.55 to 0.2, with a small increase in bleeding from 0.85 to 0.3% in selective group. But this bleeding is manageable even if diagnostic laparoscopy and lavage is needed. This has a less deleterious effect than the outcome of a portomesenteric vein thrombosis. The benefits is greatest in high-risk patients, those with high BMI, prior thromboembolic events, and patients with thrombophilia. However, routine preoperative thrombophilic workup is not supported by current evidence and remains controversial. As a summary of all these studies, we have this updated meta-analysis by Janis et al. And the team of Shatan Palmer, 76 studies, 100,000 sleeve gastrectomies, which confirms the rarity of this complication, 0.5%, but remains clinically significant. This study highlighted that the only independent predictors of portomesenteric vein thrombosis were advanced age and low center volume, and this usually emphasizes the role of experienced and standardized perioperative pathways. Although thrombophilia was present in about 1/3 of cases, BMI, sex, prior thromboembolic events, and the type or duration of prophylactic anticoagulation were not associated with the increased incidence of portomesenteric vein thrombosis. So how to prevent? This slide reflects our institutional strategy, which translated into zero thrombotic events and no portomesenteric vein thrombosis in a large series of more than 1,700 metabolic and bariatric procedures, around 1,000 of sleeve gastrectomies. The key point is consistency and standardization across the entire care pathway. Preoperatively, we optimized patients. We had a routine preoperative abdominal ultrasound, preoperative low caloric, high protein diet whenever we have a big left lobe liver span and an advanced NASH. Intraoperatively, we never exceeded the intra-abdominal pressure of 12 millimeter, except in advanced and complicated cases. We always use the 5 millimeter advanced bipolar instrument. The calibration tube is a 40 French bougie. Delivery traction, as already said, there's an intermittently on and off with the suction irrigation tool, 5 millimeter. We had we don't do over sewing of the gastric pouch to avoid kinking and narrowing, thus causing inability to drink earlier in the post-operative period. Aggressive IV hydration in the in the intraoperative and the post-operative period with early ambulation. We keep the patient usually 2 to 3 days in the hospital, and the strict and adequate oral hydration initiated at the first day. Prophylaxis, low molecular weight heparin, according to the Caprini risk assessment model. And we consult the patient early in the postoperative period, and we have a 1-week follow-up after the surgery. It is particularly meaningful that these preventive principles are echoed by Professor Michel Gagné, the pioneer of sleeve gastrectomy, and I quote him in this publication. So I think recent authors have raised the level of awareness of this complication, and I predict we will see fewer of these, and with decreased severity and surgeons, we will be doing better sleeves, larger without kinking, with shorter operative time in the near future, and they will consider longer post-operative coagulation duration and avoid dehydration at all costs. So this will summarize eventually all the take-home messages. So portomesenteric vein thrombosis is rare but potentially fatal complication after bariatric surgery. Various contributing factors that are surgery-related and patient-related. We have a wide spectrum of symptoms and sequelae. High level of suspicion with an early CT scan to avoid deleterious outcome and mortality. Extensive hydration and 4-week prophylactic anticoagulation is the cornerstone to avoid such complication. And whenever this complication occurs, better to have a multidisciplinary to manage this portomesenteric vein thrombosis. Thank you again for this opportunity, and I'm looking forward for any discussion.
Thank you very much, Dr. Rodrigue, for such an excellent presentation. Any questions from Phil, the panelists, to Dr. Rodrigue?
Yeah, well, first of all, hello to all my friends at IFSO MENAC, and I'm very honored to be here. And I congratulate the group for picking a really critically important topic. Although mesenteric thromboembolism is quite rare, it's a very serious problem. It has a high mortality. It's often very difficult to diagnose, and it's very challenging to treat. So I think it's certainly appropriate to review this topic, and congrats, Rodrigue, on really an outstanding overview. I mean, I think you covered all of the key principles of this. Preoperative risk factors, importance of early diagnosis and management, and probably most importantly, prevention. We would all really prefer to prevent this rather than to treat it. It might be worth just talking a little bit about, the etiology. The one thing is quite clear, and maybe Rodrigo, you can comment, and the others as well, is that this is somewhat unique with the sleeve gastrectomy. Um, a sleeve gastrectomy is a shorter operation, for example, compared to gastric bypass, but it has a 2 or 3 times greater likelihood of portal venous
Yes.
thrombosis. And perhaps maybe you could comment on. I have some ideas, but perhaps you could comment.
Yeah. Thank you, Dr. Shao. Thank you for the compliment. And I agree with you. In fact, actually, we have several per-operative and post-operative causes that will induce this complication. First of all, is the thermal injury. I mean, we are dissecting. We are very close to the arcade when we are dissecting our greater curvature. This is the thing that usually we don't do when we do the bypass surgery. We are really far. We go selectively and we create our pouch. This is one thing, the thermal injury. The second is usually after a bypass or other type of procedure, the patients are able to drink easier than with the sleeve gastrectomy. We've seen this with our patients to have blood inside of the stomach, a long stomach, depending on how narrow it is and how narrow is the calibrating tube. This will cause maybe a difficulty to accommodate or to ingest a lot of fluids, and that what would cause this hemoconcentration after the surgery. I mean, we insist on this in our practice. We even have someone to call the patients and ask them if they are drinking enough. And if they call us and they say, well, we are starting to have some nausea, we're not drinking enough, we bring them and we hydrate them in the ER, 1 or 2 liters of fluids. And amazingly, even if they have some sort of abdominal pain, the moment you hydrate them, the pain will magically will subside. So, but honestly, in our practice, even at the early beginning, when we don't used to put them on anticoagulation, even because we're afraid of the bleeding. Now we'll have to talk about the bleeding later on. So we didn't encounter this. The only phlebitis that we had, it was over the superficial phlebitis and a deep phlebitis in the upper extremity at the site of the IV, because in our protocol, we put our patients over 2 days. We charge them with the IV iron, multivitamins, and the trace elements, the Nutrilett or the Decount, the trace elements, to anticipate the vitamin loss in the early phase of surgery. And this was the only problem in terms of superficial phlebitis, and we have a couple of cases of deep phlebitis in the upper extremity. But other than that, we did not encounter such a complication.
Yeah, others have suggested that maybe it's the fact that we are actually altering the venous vasculature of the stomach. We, often are dividing the gastroepiploic vessels, and this perhaps altering the venous return to the portosystemic system. Do you think that might be a viable theory? And is that just inherent to the operation? I mean, we're actually removing the greater curvature of the stomach and its arterial and venous supply. Is there a way that we could alter that, perhaps to minimize that? Because that's the main difference, as I see it, in terms of the gastric bypass and the sleeve. We're actually altering the venous flow to the portosystemic system.
Actually, that we need to be really very close to the greater curvature. Try to avoid injuring the arcade, the gastroepiploic arcade. But after all, we need to dissect the short gastric vessels. So there's no way not to take down the short gastric vessels. Otherwise, we will keep on having this forgotten fundus at the upper part. And one other thing is the compression of the portal triad with the natanson or with the liver retractor. In our practice, we use a suction irrigation, and we lateralize it more to the left when you have a big liver. This is what Professor Hempens once suggested. I mean, to lateralize it to the left to be able to just lift part of the left lobe of the liver rather than, lifting it from the central and compromise the venous return. And this is what we usually do.
Yeah. Well, my last real quick comment for you and for others as well is, we're all familiar with these risk factors. They're exactly the same for DVT, pulmonary embolus, so we're all paying attention to that. But what about the one modifiable factor, and that is the postoperative, chemoprophylaxis. And, we typically will do it for 2 weeks in the higher risk patients, maybe 4 weeks. Is there a case where maybe we should extend it beyond that, beyond 4 weeks to protect individuals that may present late with this phenomenon? Comments? Anybody?
Yeah. See, I am actually interested in answering your question by challenging it. We do, and probably East Asians do a lot of gastrectomies for other reasons. Do we have literature on how much porto-mesenteric events they have in their patient category? They should have more. And question is, have they? Because I see 4 weeks is a lot to prevent a rare thing that we see in patient without surgery many times. We see it and patient comes with it as first presentation to the emergency. So the question is, did the Japanese or the Chinese or the Korean encounter this problem with their because they have a huge series of gastrectomies, and have they extended the chemoprophylaxis that much?
Yeah, I need to add for your exclamation that we started to see more and more portovenous embolic events after the COVID and the COVID vaccine. Actually, at the COVID era, we had a lot of patients who had a COVID, and then they were good after that. They were improving in the hospital, and then they called us as a surgeon and asked us to see them and as a consultation for portomesenteric embolism. So the COVID era and the COVID vaccination was linked by way or another to portal and portosystemic, portal venous events. We have to think that the incidence increased after that era because we are doing sleep from 2009. And for example, the last 5 years, I had 3 cases after the COVID era. Before the COVID era, I didn't have any cases. Maybe we were missing some patients because they had few symptoms like mild fever, but still, I didn't have these 3 serious cases that needed hospitalization for 10 days and IV fluids and IV heparin, except after the COVID era. So I want your knowledge and your observation. Did you have more cases in the last 5 or 6 years after the COVID era?
Well, Muhammad, thank you. I mean, I'll give you my experience. We had 2 patients that we postponed after COVID. We repostponed their surgeries until they were cleared from the anesthesiologist and the cardiologist, and those are the 2 patients that bled with us. So because we anticoagulated them, fearing not to have any risk of thromboembolic events, and one of them we managed her conservatively with transfusion, and the second one we're obliged to have a second look laparoscopy for lavage. So this is the other way of the story.
Thank you, Dr. Rodrigue. I think we need to move on to the next session. But there is one thing I just wanted your views on, Dr. Rodrigue. I think we all agree that recognizing and diagnosing portomesenteric thrombosis is probably one of the most difficult things. A lot of patients come in 10 to 15 days after surgery for their routine follow-up with niggling abdominal pain and differentiating those who have normal or pain within normal limits to those who have maybe potential portomesenteric thrombosis is very difficult. And obviously, you don't want to overdiagnose patients and over-investigate patients. So the dilemma is that, who to investigate? Are there any signs or symptoms that differentiate portal mesenteric thrombosis with other patients, other causes of pain?
I mean, yeah, I've mentioned it. I mean, the red flag is an increasing intra-abdominal pain. I mean, usually after a sleeve gastrectomy, this is very worrisome to us. So if we don't think about the portal mesenteric vein thrombosis, we think about the most feared complication, which is the leak for us. So those are the patients that usually they are dehydrated, tachycardic, and usually they are hemoconcentrated, and falsely they might have an increased white blood cells count. So those patients, and it is typical between 7 and the first and the third, fourth week, and those are the ones that eventually better to scan them to have a diagnosis to rule out any other complication and not to miss such a deadly with high mortality complication.
Khalid, I have a small comment. Can I share? We have run with Muhammad Kirman Saravi and other groups a multicentric international study for more than 21 centers and incorporated 77 cases of portal mesenteric vein thrombosis, and we are submitting these publications for one of the peer journals. We have seen that the death rate is 14.3% due to either bowel ischemia or the pulmonary embolism. And the significant two independent risk factor for death was one is type 2 diabetes mellitus and the high PMI patients. Thank you so much.
Thank you. Thank you very much. I think it's time to move on to our next speaker, Dr. Jassim Fakhro. He's a senior consultant bariatric and robotic surgeon at Hamad Medical Center. And today he will be talking to us about reducing bleeding rates, how intraoperative tranexamic acid improves metabolic bariatric surgery safety. Dr. Jassim?
Hello, everyone. Thank you very much for having me today in this very important and highly respectful webinar to talk about reducing bleeding rates, how intraoperative tranexamic acid improves metabolic bariatric surgery safety. So to start with, we know that postoperative bleeding remains a critical safety challenge for all of us. Despite all the surgical advances, bleeding complications continue to threaten patient safety and outcomes. And we know that from all the reported cases, the post-operative hemorrhage in bariatric surgery procedure range between 0.5 to 4%, and approximately 6% of ARD rehospitalization rate with the bleeding as a primary cause among our readmissions. There is a big challenge when it comes to using the ERAS, as the ERAS protocol emphasizes early discharge, making the detection of postoperative bleeding significantly more challenging. So, what is tranexamic acid? So basically and simply, it's a lysine analog that competitively inhibit plasminogen activation by blocking plasminogens binding to fibrin, so it prevents conversion to plasmin, results in inhibition of fibrinolysis, which is clot breakdown. When it comes to pharmacokinetics, the half-life of tranexamic acid is around 2 hours, 95% excreted unchanged by the kidney, and for administration it's always a slow IV push over 10 minutes to prevent hypertension. When it comes to the literature, there were multiple meta-analyses confirming that tranexamic acid reduced bleeding by 40 to 60%. So, Leach in 2025 published meta-analysis involving 6 studies and 1,100 patients, showing that 43% reduction in postoperative bleeding after using tranexamic acid, with a shorter operative time by around 6 minutes and a shorter hospital stay. Mukano in 2023 meta-analyzed 4 studies consisting of nearly 500 sleeve patients, showed 60% reduction in postoperative bleeding with no differences in VTE or mortality. Al-Jahan in 2024 meta-analyzed 6 studies involving 753 patients, showing 55% reduction in postoperative bleeding with a reduced operative blood loss of almost 40 ml and almost quarter day shorter hospitalization. So, tranexamic significantly reduced clinical bleeding outcomes. Evidence demonstrate meaningful improvement in multiple perioperative metrics. So when it comes to when we are measuring the most operative bleeding, as we said, 40 to 60% reduction with a significant p-value, showing fewer reoperation. There is no, I would say, p-value significant and operative blood loss, but we noticed that there have been reduction in transfusion rate. There is improved efficacy by reducing the operative time, and there were earlier discharge because shorter hospital stay. And there is 34% reduction in intraoperative bleeding, which resulted in a better visualization. When it comes to the real-world evidence, we know that 91% there have been like reduction or let's say success rate and conservative management reach up to 91% when it comes to those patients who bled after surgery. So they have reviewed around 1,400 cases. And there were only 0.4% overall reoperative rate. So is it safe? Yes, it's safe because I know that a lot of people they believe that tranexamic may increase the risk of thromboembolic events, but all the studies showed that there's almost zero thromboembolic complication at 6-month follow-up, even when prophylactic anticoagulation was continued concurrently. So, what are the perfect dose or how we administrate the tranexamic acid? So, it's around 1 to 1.5 gram IV at induction. If we're going to use it as a prophylactic, the standard dose is 1 milligram, and then some people they go as weight based, like 10 to 15 milligram per kg IV, and in a high risk patient you can go to up to 1.5 gram as a single dose. As a critical timing, tranexamic IV should be given within 10 minutes of anesthesia induction and before skin incision. Once we do have bleeding, active postoperative bleeding, then the use of tranexamic become a therapeutic use with a loading dose of 1 gram again over 10 minutes with a maintenance dose of another 1 gram every 6 to 8 hours until bleeding is controlled. So the key point, administer before or during surgery for maximum efficacy, not post-operatively for prophylaxis. So as we said, among all the meta-analysis that we have talked about, there have been 0 thromboembolic events reported in major meta-analysis. Also, none reported increased risk of seizure or acute kidney injury, and all of them, they were showing that it's been safe to use it with concurrent anticoagulation. So, randomized control study shows limited clinical significance in low-risk patients. Benczewski in 2025, he reported a single center RCT for around 240 patients who received 1 gram IV tranexamic as prophylactic. The only thing that was significant in reducing hidden blood loss, hemoglobin drainage. So, no difference in blood loss, no difference in drainage volume, no difference in transfusion requirement, no difference in hospital stay. So tranexamic has a measurable pharmacological effect but may not translate to tangible clinical benefits in unselected low-risk population managed under ERAS. So we should go, and I think let's say that if we're going to talk about using it as a prophylactic, we need to have a risk stratified approach in order to optimize the use of tranexamic. So we need to target the usage to high-risk patients rather than universal administration. So who are the high-risk patients who we are strongly recommend using tranexamic as prophylactic agent? Revisional bariatric surgeries and silver obese patients with a BMI above 50, patients who are in chronic antiplatelet therapy, known or suspected coagulopathy in those patients, history of bleeding complication, complex or prolonged procedures. Low-risk patients, routine use is not recommended. So primary LSG or Roux-en-Y gastric bypass, standard BMI range, no anticoagulation therapy, straightforward procedure, centers with low baseline bleeding rate, all those considered as a low-risk patient. In active bleeding, then it's not, prophylactic, it's a treatment. So it's been shown that's very effective for established postoperative hemorrhage. It reduced reoperation rate by 91% as showed by Klassen. Safe conservative management strategy and administer immediately upon diagnosis. So, as it is a medication, there are contraindication and precaution that we should respect. The absolute contraindication using tranexamic acid are history of venous or arterial thromboembolism, active thromboembolic disease, known hypersensitivity to TXA, subarachnoid hemorrhage, acquired defective color vision. Strict adherence protects the safety profile. Relative cautions when we are using it. Relative cautions consist of severe renal impairment, that's mean stage 3 or above. Then we need to adjust the dose. History of seizure, we need to monitor very closely. Concurrent use with prothrombin complex concentrate, hematuria or chronic hemodialysis. And the precaution for administration must be administered slowly over 10 minutes to prevent hypotension. We need to monitor the patient hemodynamically during administration, watch for hypersensitivity reaction. And for prolonged use, like that's more than 3 months, ophthalmologic monitoring is required. So the protocol for clinical implementation that we need to adopt, starting with the preoperative assessment. So we need to screen for contraindication, identify high-risk patients suitable for prophylaxis, obtain informed consent discussing risk versus benefits. Intraoperatively, we need to prepare 1 gram of TXA and 100 ml normal saline, administer that over 10 minutes at anesthesia induction, complete infusion before skin incision. And this is a very important point. Postoperatively, we need to monitor the patients and keep the standard VTE prophylaxis per institutional protocol, monitor for signs of bleeding or thrombosis, and we need to mobilize the patient earlier as ERAS guidelines. For the active bleeding, the protocol is almost the same. We need to administer 1 gram TXA IV immediately, repeat it every 6 to 8 hours if bleeding continues. Consider imaging and surgical consultation. So, is it cost effective? TXA is inexpensive, but should be targeted to maximize value. So the cost of TXA is around 2 to 5 euros per dose, significantly less expensive than reoperation, transfusion, extended stay at the hospital, and using the reinforcement material. So for a high-risk patient shows that has an excellent value because a clear cost saving from prevented complication it's been very obvious with a very low number needed to treat to prevent one bleed. In a low-risk patient, it's very questionable. Marginal benefits may not justify universal use. High NNT due to low baseline bleeding rate. Active bleeding, when it comes to active bleeding, it has an excellent value because treatment or TXA as a treatment will avoid expensive surgical intervention in 91% of cases. So what are the summary of evidence-based recommendations? So it's highly recommended for high-risk patients undergoing bariatric surgery as a prophylactic or revisionary bariatric procedure, active postoperative bleeding as a treatment, patient on antiplatelet therapy who cannot discontinue their medication. And it's not recommended for routine prophylaxis on all low-risk primary procedure, patient with contraindications, and administration should not be given, or like if you think to give it as prophylactic agent more than 3 hours after surgery onset, then it's useless. So we talk about dosing protocol before, and you know the level of evidence showed that it's level 1 when it comes to both RCT and meta-analysis. So what are the future direction that we need when it comes to research? We need a lot of research to refine patient selection and optimize protocols. When it comes to patient selection, there are a few questions that we need to answer. Which specific risk factor most predict TXA benefits? Can we develop a bleeding risk score to guide TXA use? Does TXA benefit differ by procedure type, like LSG versus RYGB, or even Omega-loop? When it comes to dosing optimization, is a single dose or multi-dose regimen superior? What is the optimal dose for a super obese patient? This timing of administration really affects the outcomes. Research regarding long-term safety. Do we need to have extend follow-up beyond 6 months for VTE risk? We need to measure safety in patients with multiple comorbidities, interaction with novel anticoagulants that's coming into the market, and the economic analysis. Is it cost effective in different healthcare systems, and what are the impacts on quality adjusted life years? So priority studies needed to determine. So I think we need to have long multi-center RCTs in high-risk population, real-world effectiveness studies, and comparative effectiveness. So at the end, key takeaways for clinical practice. Number one, it's been proven that TXA is efficient by significantly reducing postoperative bleeding and reoperation rates in bariatric surgery. It has an excellent safety profile with no increased risk of thromboembolic events or mortality. It's a very selective prophylactic, so strongly recommended for high-risk patients. It has now, we should go with a standard dosing of 1 gram IV administered slowly over 10 minutes at anesthesia induction. It's a very effective as a first-line conservative management for active postoperative hemorrhage. Clinical benefits in unselected low-risk primary cases as negligible, so we need to have, avoid routine use and be very cautious. This medication has a high value that prevent costly complication when used selectively, so it's very cost effective. So at the end, evidence supports a shift from universal prophylaxis to a targeted risk stratified approach in using TXA. Thank you very much, and please don't hesitate to throw your question. Thank you.
Thank you. Thank you very much, Dr. Jassim. Excellent review of such an important topic. I would just like to start off by asking Dr. Jassim, our panelists, in view of what Dr. Jassim just said, mentioned about the use of tranexamic acid. I agree that with any treatment that we introduce to our practice, we should be identifying high-risk patients. But as we all know, bleeding happens when you least expect it in a lot of the bariatric patients that we deal with. Now, this selective versus routine use of tranexamic acid, what are your feelings on this? Phil?
Yeah, well, first of all, Jasmine did a phenomenal presentation, and congratulations, for that. And the data he presented suggests that TXA is very effective at preventing bleeding, has no risks, and is low cost. So based on that data, we should use it on everybody, right? Now, I have to say I'm a little suspicious whenever I hear there's an agent or a procedure that has no risks, okay? I'm a little suspicious about these 4 or 5 meta-analyses that show 0 DVT. They probably weren't looking for it. If that's true, then we should use TXA to prevent DVTs. I'm always suspicious when I see a study where there's 0 complications, okay? And the fact that he'd mentioned it's the one contraindication to use it in someone who has a prior DVT. So if there's no risk of a DVT, why would it be a contraindication? Okay. So anyway, I'm just a little suspicious about that. But look, if it's $2, €2 per use, and it really stops bleeding, and the risk of a DVT is exceedingly low, then we should probably use it more widely. And I would suggest, maybe this is something for IFSO or ASMBS, other organizations, to actually come out with a policy statement on, a clinical guideline on the use. I'm not aware of such a guideline yet, but I think it would probably be worthwhile to do that.
Dr. Ala?
Now you're muted.
Thank you, Dr. Khalid, for your opportunity, and thank you, Dr. Jassim, for this outstanding presentation. But I have to share my experience. My experience is I using the tranexamic acid as a routine practice in bariatric surgery for all low and high risk patients, because I feel that there is no low risk patient in bariatric surgery, because we have a high PMI patient and we have a long stapler line, and this is the very risky for bleeding. But I use it for routine clinical practice for more than 1 year, and it really different. It make me different rate of bleeding less than that before I using tranexamic acid. So I am supporting Dr. Jassim for his presentation, and I want to ask you all the panelists and moderators who is using the tranexamic acid as a routine clinical practice and who is not using it at all.
Ala and Phil, thank you very much for your words. To be honest with you, me myself, since 2018, so now it's almost like, let's say 6 years, I'm using TXA in all my patients, and I give the same protocol: 1 gram on table at induction, and following it up with 500 milligram Q8 hours for the first 24 hours. That's it. I do my annual average is around 400 to 500 cases. So over the last 6 years, I had only 2 cases of bleeding. Only. So is it effective? In my opinion, yes, it's effective. I wouldn't say that because of that I don't have bleeding. No, definitely not. But when I see that I am using it, as you say, Phil, that it's cheap, it's not cost. The cost is it's almost nothing compared to the surgical cost. I haven't faced any complication related to TXA over the last 6 years in my practice. So why not? Why
Yeah,
not?
actually, I second Dr. Gasem and Ala. I'm using it for like 8 or 9 years last for all my patients. And actually, I was the one who suggested that we have this lecture about tranexamic acid after Rodrigue, because I knew that we will have some debates about the risk of portomesenteric or DVT after the use of tranexamic acid. I don't think, but the word I don't think is not supported by evidence. So I think today we have to start an RCT all together or in 2 or 3 centers, because lots of us right now is using it routinely, and and I have to tell the Egyptian surgeons here that it's called in Egypt cyclocapron. It's called cyclocapron. It's 1 vial 500 milligrams, and you give 2 vials in the start of your operation. So it's in Egypt it's called cyclocapron, because lots of are asking about the brand name in Egypt. So yes, we have to standardize what we are doing and then do randomized controlled trials. But still, if you have observation in many centers around the world that tranexamic acid is effective, and we have studies in other fields that it decreases the bleeding. So it was a subject that we need to discuss today. Thank you.
Okay.
Just,
No, I
just,
think
just to add one thing. Sometimes I do have patients with a family history of protein S, protein C deficiency. So those patients, they are already on a high risk of thromboembolic events. Even those patients, I put all of them on anticoagulation as prophylactic, and I use tranexamic acid. And I have around 20 to 30 patients of those. None of them had any complication related to TXA.
thank you, Dr. Jassim. Now, may I just ask you, having reviewed the literature in preparation for this talk, I'm sure you have, about the quality of the data that we have for the benefit of tranexamic acid. When you look at the incidence of bleeding, it's come down a lot. Wherever you go, it's 5 in 1,000. So the number to treat should be in the thousands, really, to pick up any clinical benefit. What are your views on the quality of the papers, the data that we have in the literature?
The literature, and meta-analysis, because I've reviewed only the meta-analysis that's been done. They were not really looking into that specifically, but they were mentioning that the number to treat, it's been very low in high risk patients.
Okay, thank you.
Dr.
Any
Jassim?
other comments?
Yeah. Yeah,
Sorry, Phil.
Dr. Jassim, thank you for very, very, very nice presentation. Actually, I don't use the TXA, but you might change my mind after this presentation. Actually, my question to you is: you give it on the induction, as you said,
Yes.
and do you anticoagulate the night before, or on the induction you give heparin,
If I
ibuprofen, or
don't,
low molecular weight, or not?
usually I give the anticoagulation only for patients with a BMI 50 and above, or if there is a family history, like a real clinical indication for anticoagulation. This is the only time when I anticoagulate. If I give an anticoagulation, I give it like on induction as well, because I'm a strong believer that those patients, if they develop thrombosis like a DVT, it's gonna happen on table, not after the surgery. And I try to do my best to have, all my patients, they do have a pneumatic compression during the OR, the operative time, carrying it with them to the room. So I use much more of mechanical prophylactic rather than chemical. Early mobilization, all of them after 3 hours they need to start moving, mobilizing, and transexamic, yes, on induction as well, and then followed by 500 milligram every 8 hours.
And a selective thromboprophylaxis. That's it.
Yes.
Well, wouldn't this be a confounding factor also, not to have bleeding in the postoperative period rather than just the TXA use?
Maybe.
Yeah.
Maybe.
No, but Rodrigo, I'm using a thromboprophylaxis for 14 days postoperatively, and I have the same result of Jassim.
Okay,
Thank
well,
you.
now we've gone past the 1 hour allocated for this webinar. I'm sure we would like to go on discussing this. Any final points, remarks that our panelists and speakers want to make before we close the session? Phil?
Dr. Shower.
Yeah, no, I must say I'm intrigued. It appears that there's a lot of use of TXA among our panelists. I'm curious as what the usage of it is, in the IFSO MENA region. In the United States, I don't think it's commonly used. This might be a nice opportunity for IFSO to put together a position statement, which may be that we need more data, but it seems like there's growing interest in the utilization of this, and I think it would be helpful for, beyond this presentation today, to have some evidence-based guidelines on the use of this. I think it would be very helpful for surgeons across the globe.
I agree with you. I think maybe, I'm sorry, Jassim, start off, Phil here threw a really good idea, which is to start with surveys to understand the practice of different surgeons in different areas. Sorry, Jassim, you wanted to say.
And I think this is a very important step, and I think me and Ala and Dr. Buzaid, we can provide you with a lot of data regarding this issue. I think the number that we're gonna have is gonna be in thousands, so it's gonna be a very strong. Yeah, it's a retrospective, but still, I think it could be a beginning before adopting an RCT.
Well, thank you very much, everyone.
Thank you. On behalf of the communication committee, I thank every professor here and every doctor in attending with us, because it's very important to have these kind of attendees and these kind of webinars. Today, we wanted to emphasize that we have the two spectrum, the DVT and the increased embolization and the bleeding, and both are very risky in our scenario, in our practice. Thank you very much for all of you to have you in these kind of respectful webinars. And I can't thank Dr. Phil enough, because I know that it's still early in USA. Dr. Khalid Hamdan, great to have you at the head of the scientific committee of the IFSO MENA. Dr. Rodrigue and Dr. Jassim did wonderful presentations, and these presentations will be I think, a milestone in future scientific work for these two topics. Dr. Ala Wafa, the co-chair, and my dear brother, he's fantastic as usual. Dr. Ali Khamas, the president of the IFSO MENA, is with us today. So it's very, very good webinar, and thank you very much for everybody. Thank you.
Thank you very much, everyone.
Thank you.
I'd like to second that and thank Stephanie for organizing this and keeping us all in the straight and narrow. Thank you very much, everyone, and have a good evening or good morning to you, Phil.
Bye. Bye.
Okay.
Bye.